Good evening, everyone. Happy Valentine's Day. Coming to you with a fourth edition of our stroke series at I Care for Your Brain with Dr. Sullivan. I am Dr. Sullivan. I am a board certified neuropsychologist and I practice in North Carolina and want to extend my reach into the world with these Facebook Lives, trying really hard to get people out there in the world who might not have access to a brain health expert, information and support. So what we've been focusing on in these last few weeks have been strokes, and tonight we are going to conclude with the final lecture in that series that will be about specific types of stroke. I'm going to continue talking about themes that relate to stroke, and in fact our next talk is going to be about neurofatigue, which affects so many of you out there that are living with the after effects of stroke. What we're going to talk about tonight is a part of the brain called the pons, and when people have had a stroke in that part of the brain, they refer to it as a pontine stroke. And this is a part of the brainstem. So I wanted to start off by getting to our handy dandy visual aids here so everybody is on the same page about what exactly it is we're talking about. So the outside of the brain here, the gray matter, is the cortex, and that is where we store all of our information. And many times people who don't know that much about the brain just think that that is all the brain is, when really the action is happening deep inside in some of what we call the subcortical structures. And the area of the brain that we're focusing on tonight is called the brainstem. So within the brainstem, we actually have a couple different structures. The pons is the major structure. And what we have is, on top of it, we have something called the midbrain. And on the bottom, we have something called the medulla oblongata, which is one of the coolest names in all the brain. And the pons is kind of right in the middle here, and it's kind of like this little bump. It is in the front of the cerebellum. Now, the cerebellum is something that we talked about a few lectures back, so if that's a part of the brain that interests you, do go back and take a listen. Even within the pons, I always want to emphasize to you all that even though these parts of the brain that we are talking about are very small, so with the pons, we're talking about 1/2 of an inch. Within it, if we were to blow up that specific part of the brain, things get very, very complicated. And so depending on where it is in the brain that you have had your stroke, you're going to get very different symptoms. And so even though we're talking about Pons stroke in general, things are way more complicated than that. Okay, so what you can see on here is all these different listings are basically clusters of brain cells that we call the nucleus of the different part of the brain. And the nucleus is a very rich, dense fiber tract that runs through a part of the brain that does a whole lot. So strokes, yes, we can talk about them as affecting certain parts of the brain, but the truth is that it's very, very, very complicated, and you really need a doctor who can understand your specific injury to give you the best information. But we're just kind of trying here to be a little bit general to help as many people as we can. So the word pons actually means bridge in Latin, and that's the way that I want you to think about it. It's a bridge in the brain that connects that outer part, that cortex, with the spinal cord and also with the cerebellum. And so it does a lot of relaying back and forth. So one way that you can think of it is that all motor control that happens throughout the whole body and the coordination of the muscles required for breathing basically run through the pons. So it's not that that part of the brain is where it all starts or where it all ends, but it's really a medium, kind of like a pit stop between a behavior starting and stopping. So it does a lot of modulating and it does a lot of feedback loops. It is very much related to breathing, and we're going to talk about that in detail tonight, but also sensations like hearing, facial muscles, a lot of nerves that control different types of things that happen in the face can be injured in these pontine strokes. And it also controls things like taste, balance, and blood pressure. So let's talk a little bit about these nerves, because these are some of the things that people can really feel as an after effect from a pontine stroke. The first one is the trigeminal nerve, and this is really responsible for the feelings that we have in our face. It also controls the muscles that help us with things like biting and chewing and swallowing and, of course, smiling. Sometimes you can get an irritation of this nerve that can cause really significant pain. And I've seen a lot of people, unfortunately, really have their quality of life reduced by this trigeminal pain, because even something as simple as the wind blowing in and hitting that nerve, it can just make it almost like, people describe it like almost being shocked, or even like feeling like they've been shot by a gun, because it can just be a very dramatic, almost like an electrical kind of shock is the way people describe it. Well, this can happen because that nerve basically can get compressed or inflamed and irritated as it exits the pons. So if we have a hemorrhagic type stroke where we have more blood in that part of the brain than should be there, we can get pressure, and that can irritate that nerve coming out of the pons. We also have nerves in the pons that are related to our eyes being able to go from side to side. That's called the abductens nerve. And there's also something that is related to our hearing and the cochlea in our ear and auditory system that allows sound to move from the ear into the brain. So all of the nerves related to these different functions start specifically in the pons. The pons has also been associated with our ability to go through the different sleep cycles. So sometimes people can have these strokes, can be left with having a hard time getting in and out of REM sleep all night long. Fewer people have brainstem strokes than have what we call cortical strokes. So remember, I was showing you in the picture here that the gray matter on top is called the cortex, and a lot of strokes happen in the cortex. We think that only about 8% of the overall strokes are actually happening at the level of the brainstem. And unfortunately, these type of strokes have a much higher mortality rate than they do in people that have them in that cortex. And in part, that's because right next to it are very important structures with names like the reticular formation that are really the cardiovascular and the respiratory centers of the brain. So if you have something, especially like a hemorrhage in the brain, like I was saying before, it's basically blood that is in there that shouldn't be in there. You can get a lot of downward pressure, and basically somebody's heart can stop, or they will stop breathing just because there's just too much pressure on those structures. So for Pons strokes that are hemorrhagic, the fatality rate is actually anywhere from about 61 to 75%, and that's pretty high. So that actually makes it hard to find good research about rehab and brainstem strokes, because the truth of the matter is a lot of people who have them don't survive. Some people who do survive, people that do survive, we either see that there's basically two ways that people can go. So there's a very severe impairment called locked-in syndrome, which is basically a condition where people can only really move their eyes. And so it reminds me of some of the later stages of Lou Gehrig's disease or ALS, and people have to use communication boards that are an interface between an eye tracking monitor and a computer to help with communication. And that is typically the only impairment that the person has. So cognitively, they're intact, but they are locked in, which I think we would all agree sounds very, very, very difficult. But on the other side, when people are surviving brainstem strokes, especially if they're just on one side, these people actually have pretty good recovery. So I want to talk to you as we go through the lecture tonight about what that would specifically look like. The thing that's really important to understand with brainstem strokes is that even though it's this very tiny part of the brain, so less than 1/2 of an inch, it can really have significant consequences because these neural pathways that run through it are just so dense. The brainstem is thought to be one of the oldest, if not the oldest, part of the brain. So the older something is through the process of evolution, the more densely packed, the more refined it tends to be. So when we think of the people that survive Pons strokes, it's typically, like I said before, people who had a stroke on one side of the pons, and there's 4 common syndromes that we think of. The first one is someone just having pure motor hemiparesis. So this is either in an arm or in a leg, just one side of the body, difficulty with movement, with coordination. We also get people who have a pure, what we call sensory stroke, which is someone who can move their arm quite good, but one of the senses, so pain or temperature or touch, is impaired. The other one is what we call ataxic hemiparesis, where the strength is still there, but the coordination is really difficult. So it's basically like a clumsy hand, and it's really hard for the brain and the hand to communicate well. The next one is dysarthria. So this probably in Pons strokes has a lot to do with the coordination of breathing. We think of breathing as something that is just automatic and it's unconscious, and it is, but it also has, there's a lot of voluntary control that happens with breath, right? So just think, you have control over how fast or slow you're breathing typically. But things like laughing, things like coughing, there's a lot of coordination that has to happen with our breathing system, and that can get very uncoordinated after these kind of strokes. One thing that is complicated in having a brainstem stroke is that it typically doesn't look like the stroke that we're all trained to recognize. So you're not going to have someone that comes in typically with a weakness in one side of the body. You're not going to have someone who can't get their words out. What you're much more likely to see is a very abrupt onset. And typically, people are having difficulty with their consciousness. So presenting to the emergency room already in a stroke is actually, already in a coma is actually not that uncommon. So typically, what we think of is things like double vision, just a hard time with general balance. Someone just can't get up out of the chair, not because of weakness, but just because of a loss of general equilibrium or coordination. We know that hypertension is the single most common risk factor associated with these kind of strokes, and that's really the case for all throughout the brain for people that have particularly hemorrhagic strokes. And so the smaller the blood vessels in the brain, the more likely they are to have a hemorrhage because they're very fragile and their diameter is very small. And what you can find is that under very high blood pressure, it's kind of a crude way to think of it, but they kind of like blow out. And so then you have this blood in the brain that shouldn't be there, and that creates its own set of problems. Brainstem strokes are strokes that happen what we call in the posterior circulation. So what you can sometimes have, like I was saying, because it's so tight back there, not only can you have the deficits that bring someone to the emergency room or the hospital, you can actually get something called a slowly evolving motor deficit, which means over time you actually get more and more stroke symptoms. So this doesn't tend to happen in most other parts of the brain. So why don't we talk about now some of these physical and sensory deficits that can happen. So you can either get a problem in the other side of your body. So remember, we've talked about, and most people know this, that the left side of the brain typically controls the right side of the body and vice versa. But in certain parts of the brain, you do have that cross, but also you can get some what we call ipsilateral control. So the left side of the pons does control some aspects of the left side of the body. Including the facial muscles. So that gets complicated because it's not like we can then look at your symptoms and kind of back logic where the stroke happened. It's definitely complicated, like I was saying at first. Some of the most significant motor deficits, though, happen with visual gaze. So remember before I was saying coordinating the eyes, specifically going side to side. People can have double vision. And a lot of what we see is difficulty coordinating breathing, and that can sometimes lead to things like difficulty with swallowing, and that can certainly affect interpersonal relationships. And when I get to the mood symptoms, we're going to circle back to that. A lot of people with Pons strokes have ataxia, which we've talked about before, which is essentially a problem with coordination of the limbs. The two areas that I think of most as happening following a Pons stroke are difficulties with the facial muscles and difficulty with the eye muscles, like I was saying before. Let's talk a little bit more about breathing, because I think that that's really, really important, and it's a great in to understand some rehab techniques that could really help you or a loved one. So the neurons, the parts of the brain, the cells in the brain that are related to breathing, are arranged in kind of a column on the brainstem. And these go up and down the pons, which is our focus tonight, but also that other part of the brainstem called the medulla. And what it does is it really controls the timing, the duration, and the patterning of our respiratory airflow. So before I was saying, like, even things like sniffing, coughing, talking, anything that you're using a coordinated breath to be able to vocalize can be affected in these strokes. So one of the things I'm always trying to come to you with are novel, interesting rehab techniques that maybe you haven't heard of before. So one of the things that I think would be very, very helpful if you've had one of these strokes is to really work on deep breathing exercises. So yes, of course, the slow and the steady deep breaths, but also playing around with breath, trying to take 4 short breaths and then maybe a long breath. The professional that would really be able to help you with this would be a speech and language pathologist. The title that they have is a little bit unfortunate because they really do so much more than just speech and language. They do a lot of cognitive therapy, memory training, but they're also very, very good at swallowing and respiration. So if you're having some of these issues, I want you to seek out that kind of a professional. Cognitively, what are we dealing with when we talk about these strokes? Well, the truth is, like I was saying before, there's not a lot of good data out there because unfortunately a lot of people who have them pass away. But we do know is that a lot of the cognition that happens in the brain, so our thinking, our processing, our memory, our language, happens in the gray matter, in the cortex. So the brainstem strokes can get a little bit stereotyped as not having any cognitive symptoms, but I have evaluated and known enough people who've had them that I don't think that that's true. And I think most good brain scientists would agree it's more that our understanding of the brainstem is not as sophisticated as the actual function of the brainstem. So probably it's that we don't really know. Some studies have looked at attention as the primary deficit, though. And what's important to know is that the degree of cognitive complaints that people have does not seem to be related to the location or the size of strokes in the pons. So it's either like you had a stroke in the pons and you're going to have some cognitive symptoms, or you didn't have a stroke and of course you're not going to have them. So it's very like black or white in that sense. We always want to be talking about mood, so let me talk to you about 2 things that are unique to these pontine strokes. One of the things I'm always trying to remind you of with any stroke is that it is an emotional, a psychological, and a traumatic experience. We can't just treat it like a medical crisis. That is inhumane, in my opinion, and we can't just take people to their medical appointments and talk about this like it's an ankle. The brain is the self, it is the person, it is the spirit, it is the person's life, it is their inner world, and we have to acknowledge that a stroke is very highly traumatic for all of these aspects of self. So the 2 things that, in addition to just a stroke anywhere of the brain, that I think of with mood when I think of pontine strokes is the difficulty with communication that can happen because of those cranial nerves that I was telling you about before. If half of the person's face is flaccid and doesn't have motor control, that can make it hard to smile. It can make it hard to get your words out. And the truth of the matter is we could do a whole talk about people's tendency to ignore people of difference, particularly if they're not feeling like communication is effortless. A lot of people who are living with brain injuries are ignored, and I think it's one of the dirtiest little secrets that we have as human beings is why do we do this? and I think it would certainly be worthy of a whole talk in and of itself. But people who have had these strokes will tell you, my personal life, my social life is absolutely affected. The other thing is that there is something called Pseudobulbar Affect that is a disorder of emotional regulation that is characterized by uncontrollable big bursts of emotion. So crying very quickly, laughing when it doesn't necessarily seem to be that funny to other people. But what we know is that this happens more so in people with brainstem strokes. We don't really know exactly why this happens, but we do know that there is the most influential theory that we have talks about that these outbursts are kind of generated in the brainstem, and then we might also have some loss of control by the frontal lobe. So, you know, we're all having big impulses and all sorts of kind of primal thoughts and feelings all day long. Yes, even you, even me. And our frontal lobes are kind of the dampening down. They're the brakes. Remember that we've talked about this before. Your frontal lobes have so much to do with your brake and your gas, right? Being able to stop something, but also being able to start something. So if you remember, one of our rules is that everything in the brain is connected. It's either connected physically or it's connected chemically. So even though we're talking about a part of the brain that's all the way back here, believe it or not, we are going to see indirect effects in the frontal lobes. And so that's part of this idea with pseudobulbar. It's certainly not life-threatening, but it's something that can really affect people's quality of life. So now let's move into talking about rehab, because the whole point of education is to do something with it, right? So now we understand a little bit better about brainstem strokes. What are we going to do differently because we now know better? So let's just take a little bit of a step back and just talk about stroke recovery in general. The most important thing is intensive, repetitive rehab therapy, okay? And either you're going to get it with professionals or you are going to have to keep it going on your own or for a family member. There's a lot of controversy right now about access to rehab therapies. There is the Medicare cap, which is driving us all completely crazy, people who care about people with brain health conditions. Where people can basically get about $2,000 a year worth of rehab services, which is basically gonna like get it started. And it's up to you. It's unfortunate, but the truth is you are going to have to understand the principles of rehab and really be able to implement an ongoing rehab program for yourself. The only way to get better is to be at it every single day. And so one of the things I like to say is that I want everything in your life to become rehab, but I don't want your whole life to only be about your brain injury and your rehab. It's kind of a hard balance that I'm asking you to do, but it's very important to me that your entire identity does not circle around your brain injury, whether it's a traumatic brain injury or a stroke, because there are a lot of other aspects of yourself that are the same and will always be the same. But the truth is, the brain is a very unique organ, and we have to keep at it, keep at it, keep at it. But I also want you to do plenty of other things that aren't typical rehab exercises, but if you do see them through the lens of rehab, almost everything can become therapeutic. So we used to think that brain rehab started and stopped at about 6 months, and then we said a year, and then we said 2 years, but you know, if you've been listening to me, that that is BS, and recovery from a brain injury will happen until the day that you die, and you will get as much out of it as you put into it. One thing that's interesting when we're talking about brainstem strokes is that all of this talk about brain plasticity and functional reorganization of the brain has really been focused on damage to the cortex, so to that gray matter that we commonly think of. We know much less about the plasticity of brainstem circuitry, and that's certainly an area of functioning that we need to be able to get better at in terms of science. But we absolutely know that there is enough white matter running through the brainstem that theoretically it makes sense that you should be able to get the same reorganization out of it that you do with the cortical stroke. So I want you to just assume that those principles apply to you. Like I said before, with rehab and brainstem strokes, it's kind of extreme in both directions. So if you survive, a lot of people feel really strongly that you have a great chance at a good recovery because there's typically not a lot of big cognitive problems. People never have aphasia as it relates to a Pons stroke, and that can really get in the way of rehab because if the person doesn't comprehend language, they don't understand instruction, it's very, very, very hard to build on that. So one of the things that we think of is that if we can help someone with physical therapy and with vision rehab, that they have a really great chance at getting a lot of the other deficits back to pretty close to where they were before, which I think is absolutely fantastic. We really want people to be very intentional with their rehab. So one of the most important things is repetition. I had recently read a study that showed that it takes about 1,000 repetitions to be able to see and to be able to measure an effect after physical rehab. And I just thought, gosh, that's so important for people to know, because maybe you do it, 500 times and you get discouraged because you don't see a big significant impact. Well, 1,000 times, that's a lot. But if you train yourself to look at what I call the micro victories, you will always see improvement, and that is what is going to keep you motivated to keep coming back to your rehab time and time and time again. As we close this lecture series on stroke, I really hope that you have become more understanding about neuropsychology and what we as neuropsychologists do, that we are really experts in brain and behavior. And I think that we're in a wonderful position to help people with stroke because not only do we have the expertise about the brain, but we really went into this field because we care about how it affects you as people and how it's affecting your family and your ability to live a life of quality. So if you have not had an evaluation by a neuropsychologist, I really, really want to encourage you to talk with either your neurologist about that or your primary care provider. There is a great resource on Google. If you put in find a board certified neuropsychologist, you can get to the webpage for the American Board of Professional Psychology, which is the board certifying body that certifies us. And you can actually put in your zip code, and they'll tell you within 15 miles of your house, within 50 miles, all the different neuropsychologists that you could be referred to. Now, you might have to advocate for this on your own, but I think that you can do it. And now that you see the benefit, this might be something that you follow up on. Certainly, everyone who's had a stroke would benefit from an initial evaluation, and this will help you understand your strengths, your weaknesses, how to target your rehab, making sure that there's no mood problems there that could be hindering as much progress as you could be making. But really, follow up with a neuropsychologist is very valuable. Some of my best appointments throughout the day are people that I check in with every 3 months, every 6 months, so I can constantly be giving them feedback about where to focus their energies. I also wanted to tell you that through this series, and specifically through my listening and participating in some Facebook groups, I have become very motivated to write what I'm calling a stroke recovery guide, which will have the 10 essential rules of rehab in it, because it's very painful for me to hear people who don't have access to brain health experts or don't have insurance, who don't have the ability to do the intensive rehab that they know will help them get the best outcome. So what I'm trying to do is write this guide. It's kind of it was 3 rules at first, and then it has become 10 rules, but I'm working on it really hard right now in order to be able to give you all access to the basic principles, because I really believe that a lack of education and a lack of access to information is holding you back in your recovery, and we just can't have that. We just can't have unnecessary suffering, and we can't have unnecessary progress. We can't have a lack of progress happening just because people don't have the information. I refuse to be a part of that system, and so I'm going to try really hard to write what I hope to be a really, really great recovery guide. So thank you guys so much for being with me. The truth is, I'm still not 100%. My whole family had the flu last week, and I'm still slightly a little bit out of it, but we have Valentine's Day and we have roses. So thank you guys so much for being with me. Next time I'm going to talk about neurofatigue and why you guys are all so tired after these strokes and what it is that you need to know and what it is you can do about it. Thank you so much. If you found this helpful, please like it, please share it. Very important to spread this information to people that care about you, because believe me, they want to know. Thank you guys so much and have a great night. Bye-bye.